Once upon a time, a patient walked into your office with the new diagnosis of type 2 diabetes, and you wanted to get his blood glucose under control. But there were too many options for therapy: dietary modification and exercise for weight loss, oral agents, non-insulin injectables, insulin injectables. What to do? Then you recalled the classic Brothers Grimm tale, Langer, Hansel, and Gretel, and it all became so clear. This sketch is going to focus on insulin analogs, or agents that increase your natural endogenous insulin secretion. The second video in this chapter will instead illustrate the agents that act at peripheral tissues to decrease resistance to insulin. We'll even go straight to the source and block glucose release and absorption. This first video, however, is all about insulin. Insulin is the storage and anabolic hormone of the body. At Sketchy, we represent insulin with a welcome inside mat, such as this one here that invites lost children into this creepy high-carb cottage. Just think of insulin as the hormone that welcomes glucose and fat inside the cell, either for storage or to facilitate cell growth and metabolic functions. Insulin comes from the pancreas. Specifically, insulin is produced by beta cells in the islets of Langerhans, where it's stored in granules waiting to be released. Enter poor little Langerhansel, abandoned in the forest by his parents. Can you blame his evil stepmom, though? I mean, those are harsh times with that famine and all. Too many mouths to feed. Langerhansel, of course, embodies the islet of Langerhans. And to remind you that insulin is produced by beta cells specifically, little Langerhansel holds out our recurring beta 2 tuba. As he sounds a distress call, hoping that some friendly, preferably non-cannibalistic passerby will come to his aid. Recall that beta 2 tuba is our recurring Sketchy symbol for the beta 2 adrenergic receptor. Turns out that there are many stimulants of insulin release, including direct sympathetic activation of beta 2 receptors on the beta cell. However, the most potent stimulator of insulin release from the beta cell is glucose. Oh, and it looks like Langerhansel's found some glucose now. But what's it doing here in the middle of the forest? He wants to take a bite, but can't shake the feeling that someone is watching him. When he does take a bite out of that mysterious forest candy, here's what happens. Glucose enters the circulation, eventually making its way to the beta cells of the pancreas. Here, hyperglycemia results in increased intracellular ATP levels. Just imagine that excessive glucose influx into the beta cell leads to an overabundance of energy. In other words, too much ATP. See that closed gate meant to keep lost forest children from wandering around in that eerie flower garden? It's the key to this whole insulin-releasing process. Special ATP-gated potassium channels close in response to increased intracellular ATP, depicted by this closed gate preventing access to that whimsical, yet creepy, banana-flavored potassium candy flower bed. Closed potassium channels means decreased potassium efflux, resulting in depolarization of the beta cell. Enter Gretel, Langerhansel's carefree younger sister, who's decided to make the most of this otherwise disturbing predicament. What? Ice cream just grows on flowers here? Don't mind if I do. Membrane depolarization of the beta cell activates voltage-gated calcium channels. Gretel here depicts the ensuing influx of calcium as she bends that calci-yum ice cream flower over the garden wall. It's this increased intracellular calcium that stimulates the beta cell to secrete insulin. When the beta cell releases the contents of its granules, another peptide enters the circulation as well, called C-peptide. It turns out that insulin first exists as a larger precursor molecule, proinsulin, when it initially enters beta cell secretory granules. Within the granule, proinsulin is cleaved by beta cell peptidases into mature insulin and a C-peptide remnant. C-peptide and insulin are then secreted from pancreatic beta cells in equimolar concentrations. Think of proinsulin then as a piece of candy still in its wrapper, It's unwrapped by the beta cell, and both insulin and its wrapper are released, just like these C-peptide candy wrappers left behind by Gretel and Langerhansel as they munch on that insulin-inducing forest candy. Keep those C-peptide candy wrappers around Langerhansel in mind as we introduce the other agents in the sketch. The only time you'll be able to measure C-peptide in the serum is when pancreatic beta cells are producing and excreting their own insulin. When you administer an insulin analog exogenously, an insulin shot for a type 1 diabetic, for example, you're bypassing the body's normal endogenous synthesis of insulin and C-peptide. And C-peptide will not be measured in the serum. After insulin is released by the beta cell, it enters the circulation and diffuses into tissues where it binds to the insulin receptor on the surface of target cells. The receptor spans the cell membrane and contains an intracellular tyrosine kinase domain. Just think of this tyrosine kinase tire swing as the membrane of this inviting insulin cottage. Binding of insulin causes a conformational change in the receptor, activating tyrosine kinase activity. This sets off a cascade of phosphorylation events, eventually leading to translocation of glucose transporters to the cell membrane. At peripheral tissues, the main glucose transporter is GLUT4, so we've incorporated the number 4 into the cottage's open door. Once GLUT4 is in the membrane, now glucose can get inside your cells. It's not just about glucose uptake though. Activation of the insulin receptor jumpstarts a number of anabolic processes inside the cell. At hepatocytes, for example, activation of the insulin receptor leads to increased synthesis and decreased breakdown of glycogen, the storage form of glucose. This is depicted here by this liver-shaped candy jar filled to capacity with stored glycogen candies. So enticing. At skeletal muscle, insulin stimulates increased glycogen storage as well as increased protein synthesis. Just think of this delicious honey glazed ham. Not only is it packed with stored protein, it's covered in a delectable glycogen glaze. Must resist. At adipocytes, insulin stimulates the storage of triglycerides, just like these fatty triglyceride-ridden donuts stored in the fat cell here. Oh God, looks so good. Okay, I'm just gonna go over here. Check it out. What's the worst that could happen? Oh, finally, we lay eyes on the hideous old hag who has laid out these enticing treats to lure unsuspecting children into some kind of disturbing toddler bakery, no doubt. Notice the potassium banana flour in her hand as well. As she takes a bite, remember that insulin administration lowers serum potassium concentrations by driving potassium into cells. This is primarily by enhancing the activity of the sodium-potassium ATPase in skeletal muscle. You know what? I don't know why I was so quick to judge. I mean, she looks friendly. Oh, look, there's a message. Let's see here. Girls and lads, rest now, don't go. Aw, see, I told you. Why don't we stay a while? This eerie, inviting message is going to embody the numerous types of injected insulin that are available. You've got rapid-acting analogs with short duration of action, intermediate-acting preparations, and long-acting agents with a slow onset of action. Insulin regimens usually involve the use of a long-acting insulin analog to provide basal or background coverage and rapid-acting insulin analogs to meet mealtime requirements. Let me show you what I mean. First, our rapid-acting short-duration agents. The names of these insulin analogs are incorporated into girls and lads sign. Insulin glulisine, aspart, and lispro. Due to various amino acid modifications, these agents do not polymerize into hexamers like regular insulin. So after subcutaneous administration, they're absorbed more rapidly. Let this tall, jutting peak in the gingerbread house remind you of the rapid peak in insulin concentrations produced by these agents. They have an onset of about 15 minutes and peak in 45 to 75 minutes, a pattern that closely mimics the normal endogenous postprandial insulin response. Therefore, short-acting agents such as insulin glulisine, Aspart, and Lispro, are helpful for controlling that postprandial glucose spike. Just remember these cute little postprandial birds nibbling away the initial peak of this gingerbread house. Next, the intermediate-acting insulin agents, regular insulin and neutral protamine Hagedorn, or NPH. Their names represented by the rest now sign. First, notice the peak at this section of the gingerbread house is more delayed. When given subcutaneously, regular insulin starts working within 30 minutes, peaking in 2 to 4 hours. The more delayed onset of action of regular insulin is due to the formation of dimers and hexamers. These take time to dissociate after injection, causing some absorption delay. This makes regular insulin less useful for controlling that rapid postprandial glucose spike. However, regular insulin is the only type of insulin that can be administered IV for special situations. Hence, our recurring ubiquitous IV. When prepared for IV injection, the dilution of hexameric regular insulin immediately dissociates into monomers. It therefore has a rapid onset of action, particularly useful in the management of diabetic ketoacidosis. Diabetic ketoacidosis is a medical emergency caused by inadequate or absent insulin replacement. So all the glucose builds up in the serum, locked out of the tissues because insulin isn't there to bring it in. Your body becomes starved for glucose, so your liver starts to release ketones, an alternate energy source for your brain. This combination of elevated serum glucose with elevated serum ketones is depicted by this high glucose candy cane key. Think diabetic ketoacidosis when that 21-year-old presents to your emergency department after several days of dizziness, vomiting, fatigue. He's been drinking a lot and he's been peeing a lot. You check his urine and bingo, you see glucose and ketones. That patient's vomiting and dehydration, along with glucose and ketones in the urine, are consistent with diabetic ketoacidosis, or DKA. What's next? Well, along with starting IV fluids, let's get that glucose into his cells. IV regular insulin is your agent of choice here, lowering serum glucose and ketone levels within minutes of administration. Sub-Q insulin should not be used in these patients because it's harder to control, and they're usually severely volume depleted, so absorption under the skin won't work very well. See this other strand of IV heading toward the consumed potassium banana? While you're loading this patient up with IV insulin, remember that you're also driving potassium into cells, leading to hypokalemia. So get some potassium ready to replete that falling serum potassium concentration. This effect, however, can come in handy when you're trying to treat hyperkalemia. IV insulin can be used to rapidly bring that serum potassium down. Remember, you're driving glucose into the cells as well. To avoid hypoglycemia, insulin is delivered along with glucose. All right, all this talk about regular insulin. What about NPH, the other half of the rest now sign? Well, the action of NPH is more unpredictable, so it's not used as much clinically. Just remember that it's an intermediate-acting insulin with delayed absorption and an onset of action within 2 hours. Okay, let's move on to the long-acting insulins, insulin detamir and glargine. Their names represented by the don't go sign. Notice that the roof at this section of the gingerbread house is long and flat. When given as a regular daily regimen, long-acting insulins provide a long, steady basal level of insulin. You see, diabetic patients often need 2 types of insulin, a postprandial short-acting insulin to control glucose spikes after eating, and a basal long-acting insulin for that constant background insulin activity throughout the day. The best basal long-acting insulins are glargine and detamir insulin, administered as shots 1 to 2 times daily. Glargine is the longest acting, lasting for about 24 hours without a distinct peak. Because you're driving all this glucose into cells, hypoglycemic reactions are the most common complication of insulin therapy. In this sketch, whenever we want to emphasize that an agent has increased risk of causing hypoglycemia, we'll include these red, overly ripe glucose candies falling off the tree. kind of like falling serum glucose levels. Hypoglycemia can cause signs of autonomic hyperactivity, both sympathetic, such as tachycardia, palpitations, sweating, and parasympathetic, such as nausea and hunger. It may even progress to convulsions and coma if untreated. Glucose can be given by mouth, or in a stuporous or comatose patient, glucose can be given IV. An intramuscular glucagon injection also works well. Just remember, glucagon for when your glucose is gone. Alright, as the sulfonylurea swan enters the scene to warn the kids of this witch lady's ulterior motives, we're going to shift focus a bit. Exogenous insulin administration involves the agents we've just discussed. It's essential to the management of type 1 diabetes. That's because in this condition, you can't make insulin. Type 1 diabetes mellitus usually results from autoimmune destruction of the insulin-producing beta cells in the islets of Langerhans. So you need to give them insulin exogenously. Now, type 2 diabetes is usually characterized by insulin resistance. In other words, in the early stages of the disease, your pancreas can make its own insulin. Your body's just resistant to it. As type 2 diabetes progresses, beta cells start to fail, and many patients will also be on an exogenous insulin regimen. However, while there are still functional pancreatic beta cells around, there are a few ways to give them an extra boost and upregulate your body's own insulin. One class of agents that does this is the sulfonylureas, represented by the sulfonylurea swan, of course. Also, to help you remember that we're talking sulfonylureas here, we've included our recurring symbol for sulfa drugs, some stinky sulfa-ridden swan eggs. While insulin is injected, these agents are taken orally to stimulate endogenous insulin release from beta cells. Remember, for endogenous insulin release to occur, ATP-dependent potassium gates need to close. Well, sulfonylurea works the same way, by binding the potassium channel, shutting it off. And that's why this sulfonylurea swan is behind that closed potassium gate. This leads to the normal sequence of events. The beta cell depolarizes, calcium rushes in, and the beta cell releases endogenous insulin. Keep in mind that whenever we're stimulating normal insulin release, those C-peptide candy wrappers get released as well. So you will measure increased C-peptide in the serum with these agents. Okay, I just want to briefly run through the specific generations of sulfonylurea agents so that you recognize them on the exam. The first generation includes tolbutamide and chlorpropamide. They both have that "mide" suffix, so we've given our sulfonylurea swan a "maid" outfit. These first generation agents have to be given in larger doses, and you won't see them on the exam as much. Second generation sulfonylureas are way more potent and are administered in smaller doses. These agents include glyburide, glimepiride, and glipizide. When you think of these second generation agents, glyburide and glimepiride, think of these second generation goslings riding on the back of Mother Goose here. Wait, is this a swan or a goose? You know, I never could tell the difference. Glipizide is the shortest half-life of the more potent second-generation agents. Think of glipizide as this glipizide gosling making some Z's in the water as he zigzags along beside his mom. The meglitinides are another class of oral anti-diabetic agents, similar to the sulfonylureas. The meglitinides include repaglinide and nataglinide. To help you remember that glinide suffix, just think of this Father Goose gliding into the scene. Meglitinides are short-acting glucose-lowering medications with a mechanism of action very similar to the sulfonylurea agents below. In other words, they bind potassium channels, shutting them off, leading to depolarization of the beta cell, calcium influx, and release of insulin. This is endogenous insulin production we're talking about here, so remember that C-peptide is released as well. Also remember, this is a Father Goose, so no laying those stinky sulfa eggs. Repaglinide and nataglinide are not sulfa drugs and can be used in patients who experience an allergy with the sulfonylureas. Because of their ability to increase endogenous insulin release, regardless of blood glucose concentration, Both sulfonylureas and meglitinides carry a significant risk of hypoglycemia. Just like with those insulin analogs, we're going to represent this increased risk of developing hypoglycemia with these red, overly ripe glucose candies falling off the tree, kind of like falling serum glucose levels. Hypoglycemia is more common with long-acting sulfonylureas and in elderly patients. Because we're releasing endogenous insulin here, remember that activation of insulin receptor does not only facilitate glucose uptake. Insulin jumpstarts a number of anabolic processes inside the cell. This includes storage of triglycerides into adipocytes. Hence, another adverse effect of meglitinides and sulfonylureas is weight gain. One other side effect to mention: some of the first-generation sulfonylureas, such as chlorpropamide, can cause a disulfiram-like reaction with ingestion of alcohol. So, next to our first-generation chlorpropamide made, well, just read the sign. I know it's tempting, but just don't. Just to kind of sum up the sulfonylurea swan and the meglitinide gliding goose, I want to reiterate that these agents need functional beta cells in order to work. They upregulate endogenous insulin secretion from these cells. So these agents are for the management of type 2 diabetes. In type 1 diabetes, remember, the beta cells are being destroyed. With type 2, on the other hand, yes, you've got insulin resistance, but there are still some functional beta cells sitting around that could use that extra push. All right, on the other side of the scene, we're going to illustrate our next class of oral anti-diabetic agents, the GLP-1 agonists, which include exenatide and liraglutide. Ooh, just another friendly old hag doing some laundry with exenatide detergent. GLP-1 agonists work at the same receptor as the endogenous hormone GLP, or glucagon-like peptide. So when you think of exenatide or liraglutide, think of activating the GLP receptor, just like this frightening old lady is activating a GLP gulp out of poor Langerhansel here. Freaky. Glucagon-like peptide 1, GLP-1, is normally secreted by intestinal L cells in response to food intake. And funny enough, it's like the opposite of glucagon. It decreases blood glucose by inducing satiety, decreasing gastric emptying, reducing glucagon release, and increasing insulin release from the pancreatic beta cell. So while GLP-1 agonists act like GLP, our next set of agents work to increase your own endogenously secreted GLP instead. These agents inhibit dipeptidyl peptidase 4, or DPP4, the enzyme responsible for the breakdown of GLP. To remind you that these are DPP4 inhibitors, we've illustrated 4 dripping garments on the clothesline. Those look a little small, don't you think? The DPP4 inhibitors include sitagliptin, saxagliptin, and linagliptin. They've all got that gliptin suffix, so we've made the dripping laundry hanging from gliptin clothespins. Remember, inhibiting DPP4 means increasing your own endogenously secreted GLP. Just think of this laundering old hag increasing her endogenous GLP as she unintentionally lets out a GLP gulp of her own. Oh, I get it now. It's the clothing from the last batch of children that they murdered. It's so clear now. That is awkward. Remember, with increased levels of GLP, you've got enhanced secretion of your own insulin from beta cells. In addition to its insulin stimulatory effect, however, GLP has a number of other biological effects, including suppressed glucagon secretion and delayed gastric emptying. At Sketchy, glucagon is represented by sweetener packets because glucagon is responsible for gluconeogenesis and glycogenolysis, processes that normally increase your blood sugar. So these agents increase GLP or act like GLP. They suppress glucagon, depicted by these spent glucagon packets littered around the witches. And this aids in lowering serum glucose levels. Also, these GLP agents delay gastric emptying, as depicted by this sealed stomach water container. Delayed gastric emptying leads to increased satiety and delayed glucose absorption, and both effects aid in lowering serum glucose. A couple adverse reactions to mention. Turns out that gliptins can cause upper respiratory tract infections and nasopharyngitis. Hence, the gliptin clothespin clasped onto the witch's nose. Also, all those GLP-1 receptor agonists may increase the risk of pancreatitis. So we've added our recurring pancreatic sponge to that creepy exenatide detergent lady. Any patient who experiences unexplained persistent abdominal pain should seek immediate medical care. All right, all those GLP agents on the right enhance insulin secretion, so they should cause glucose to be driven into cells, leading to hypoglycemia, right? Well, not quite. It turns out that GLP's effects are glucose dependent and diminish as glucose levels approach normal. So the GLP receptor agonists, such as exenatide, as well as those gliptin GLP enhancers, do not cause hypoglycemia. While before we had represented hypoglycemia with those red, overly ripe glucose candies falling off the tree, kind of like falling serum glucose levels, this time those fantastical candy fruits are still green and attached to the tree. Nope, no precipitous falling glucose here. Overall, remember that these GLP agents need functional beta cells in order to work. They upregulate GLP concentration or receptor activity, which enhances endogenous insulin secretion from beta cells. So these agents are for management of type 2 diabetes. In type 1 diabetes, remember the beta cells are being destroyed. With type 2, on the other hand, yes, you've got insulin resistance, but there are some functional beta cells sitting around that could use a little boost. Also, keep in mind that because these agents work by stimulating the release of endogenous insulin from pancreatic beta cells, you've got insulin and those C-peptide wrappers sent into the circulation. Think of C-peptide as a marker of endogenous insulin secreting capacity. All right, let's sum up this grim fairy tale. Insulin is the storage and anabolic hormone of the body. When you consume a glucose load, ATP levels increase in the pancreatic beta cells. Potassium gates close, the cell is depolarized, calcium rushes in, and insulin is released. When your own beta cells are secreting insulin, C-peptide is released as well. When insulin is given exogenously, that's insulin only, no C-peptide. Insulin regimens usually involve short-acting for meals and long-acting for background coverage. Remember, girls and lads, rest now, don't go. Glulisine, Aspart, and Lispro are your short-acting insulin analogs that control that postprandial glucose spike. Regular insulin and NPH are more intermediate acting. Regular insulin can be administered IV to treat diabetic ketoacidosis and to emergently decrease potassium levels and hyperkalemia. Insulin, detamers, and glargine are your long-acting agents for that steady basal level of insulin. All of these insulin analogs may cause hypoglycemia, as depicted by the ripe falling glucose candies. On the left, we've illustrated agents that enhance the endogenous release of insulin from functional beta cells. This may be helpful in type 2 diabetes when some functional beta cells remain. The sulfonylureas are embodied by the sulfonylurea swan and includes the chlorpropamide MAID and the glyburide and glipizide goslings. They're behind the closed gate because they shut down the ATP-dependent potassium channel on the beta cell, which stimulates endogenous insulin release. The glinides that are gliding in work the same way. With all this insulin release, again, there's a chance of hypoglycemia. And over on the right, we've illustrated the agents that lower serum glucose through the actions of GLP. Exenatide acts at the GLP receptor, while the gliptins inhibit the breakdown of endogenous GLP by inhibiting that drippy DPP4. No hypoglycemia here. For our next sketch, we'll shift focus from increasing insulin activity to decreasing your body's resistance to all this insulin. All right, I don't know about you guys, but all this talk about glyburide and glipizide and goslings has me thinking of one thing only: Ryan Gosling. So before you move on to the next sketch, give me about 3 hours to rewatch The Notebook, That extra hour, of course, for mandatory post-credits crying session. You're all invited.